3, 2, 1.
Good evening, colleagues, and welcome to one of the final in the series of our webinars where SADA brings you from your couch to the respective dental schools of South Africa. Tonight, we find ourselves in the warm and cozy embrace of the University of Pretoria. And before I present to you guys our speaker for tonight, just a few house rules regarding tonight's webinar. Kindly refrain from reusing the raise hand feature, and please type your comments and questions in the Q&A tab. Your CPT certificate will be uploaded on the SADA platform, which you may access on your member profile. And for those non-SADA members, you will be able to create your own profile and access your certificate. Tonight's webinar carries one clinical CEU. And for those of you guys who are unable to catch us on Zoom, we will also be live on YouTube. So you may stream us on YouTube Live. Now, before I introduce our speaker tonight, I want to thank your delegates for availing yourself on a chilly Thursday evening. Our speaker tonight is Dr. Christa Blignaut. A little bit of information about Dr. Christa. She completed her pre-graduate training at the University of Pretoria in 2011. Just 1 year after our 2010 World Cup. And in the year 2013, post-community service, she decided to dive into the adventurous world of private practice. However, during this time, she also completed her certificate in implantology, as well as her diploma in implantology at the University of Pretoria and the ITI Center of Excellence. She's currently a second-year registrar in the Periodontics and Oral Medicine department at the University of Pretoria. Our speaker tonight is Dr. Christa Blignaut, who will be enlightening us on the role of corticosteroids in dentistry. Dr. Blignaut, the floor is yours.
Thank you, Dr. Sudhir, and thank you, Sara, for this opportunity. Okay, please allow me just to also share my screen. Okay, so Dr. Sudhir, can you see my screen?
Yes, I can.
Okay, perfect. Okay, so welcome to this glucocorticoid lecture. We are going to discuss various aspects of glucocorticoids, mostly at the hand of clinical cases. But first, let's put steroids into perspective. So when we talk about steroids, we must make a clear distinction between different types of steroids. Steroids are all various forms of a 4-ring structure and are all molecularly similar to cholesterol. Changes to this ring leads to the difference in mineralocorticoids versus glucocorticoid attributes. This also affects the anti-inflammatory and the immunosuppressive effects. So the adrenal cortex is part of the adrenal gland, and this is responsible to make 3 types of steroids. So firstly, on the left-hand side, you can see glucocorticoids. The main glucocorticoid is cortisol. It has influence on the inflammatory process and the immune system, predominantly involved in the lipid, protein, and carbohydrate metabolism. In the middle, we have mineralocorticoids. Here, the main mineralocorticoid is aldosterone. It is responsible for the water and salt balance in the body. Then lastly, on the right-hand side, we have adrenal androgens. Here, the DHEA, which is your dehydroepiandrosterone, is the major adrenal androgen. This is a precursor for male and female hormones. So many people are familiar with anabolic steroids, right? These are the male and female specific steroids and should be clearly differentiated from the steroids that we are discussing today. Anabolic steroids are associated with athletes and have caused scandal in the past as it enhances athletic performance, and it also builds muscle tissue. Corticosteroids will not make you faster and it will not make you stronger. We use it for an entirely different purpose. We are focusing on glucocorticoids, and to understand the medicinal application of these steroids, we have to consider how they are secreted. sleep, stress, and the circadian rhythm, together with two endogenous hormones, contribute to the secretion of cortisol. The hypothalamus in the brain secretes the CRH, which is also your corticotropin releasing hormone, leading to the anterior pituitary gland secreting ACTH, or also often called corticotropin. So corticotropin from the pituitary gland is responsible for secreting cortisol from the adrenal glands. The cortisol that is released provides a negative feedback loop to control the inhibition and secretion of both corticotropin and CRH. This system of secretion is called the HPA axis, your hypothalamus pituitary adrenal axis. And that is the picture that you can see on the left-hand side. It contains both a positive feedback loop on the left to secrete cortisol, but also a negative feedback loop on the right to ensure a balanced amount of cortisol is released. Now it's important to know cortisol is not stored in the body. So as soon as cortisol is made by the adrenal glands, it is secreted into the bloodstream. It follows a circadian rhythm of secretion, which is also the picture on the right-hand side, with the highest level of cortisol being secreted early in the morning, and then the levels decrease during the day. Physical and mental stress are powerful activators of cortisol. It can increase your cortisol levels from the normal 20 to 30 milligrams per day to up to 200 or 300 milligrams per day. Exogenously synthesized corticosteroids are made from animals and plants. The supraphysiological levels cause suppression of this HPA axis. This can lead to physical atrophy of the adrenal gland, which renders the gland unable to produce sufficient cortisol when you need it. Patients that become reliant on these exogenous drugs often require larger dosages during peak periods when they experience peak episodes of stress or surgery or infection. The effects of exogenous glucocorticoids can be long-ranging, with effects being present months to years after the treatment has been stopped. These lingering and cumulative effects are affected by the dose, the potency, the frequency, and also the duration of use of glucocorticoids. The structure of these drugs also determines its duration of action and potency, like you can see in the top right-hand corner. This allows us to classify these agents according to their duration of action. First, we have our short-acting drugs, namely cortisone and hydrocortisone. Cortisone replicates the action of cortisol. And then secondly, in the middle group, we have our intermediate drugs. And lastly, we have our long-acting drugs. As you can see on the screen, the most potent glucocorticoid also has the longest duration of action. The potency and the duration of action determines the most appropriate use, the treatment strategy, and also the potential to suppress the HPA axis. So if we look at these drugs, and we start by hydrocortisone in the green block, it mimics cortisol, as it has the same potency and relative anti-inflammatory and sodium-retaining properties. So those are equal. Then in the intermediate group, these drugs are most commonly used systemically. Prednisone is rapidly converted in the liver to prednisolone, which is its active form. These drugs are employed in the treatment of cancer, allergy, and various autoimmune disorders. Then lastly, in the bottom, the long-acting drugs. Now these show a 30 times stronger anti-inflammatory and immunosuppressive effect compared to cortisol. So at the bottom, the blue block is dexamethasone. Some of you might be familiar with this. It has been in the news last year a lot as the World Health Organization put this drug on its 2020 guidelines for the last line of treatment for COVID patients ventilated in ICUs. So this is a very potent drug. In many situations, the body responds with exaggerated inflammation or an inappropriate immune reaction. This is where the very powerful anti-inflammatory and immune modulatory effects are utilized, and we call it the good effects of glucocorticoids. The homeostatic objective of glucocorticoids is to enhance healing while simultaneously limiting structural damage. Glucocorticoids act primarily on various leukocytes, like you can see on the left-hand side, that picture. It suppresses the activation of T cells and the messenger molecules that they release. It prevents the release of histamine and prostaglandin, and we know that they are responsible for the edema, the tissue damage, and the vasodilation associated with inflammation. So, if we think about it, by decreasing inflammation, we also decrease the associated tissue damage. Then, another thing is that glucocorticoids cause vasoconstriction and decrease vascular permeability. The number of circulating lymphocytes is also decreased. By decreasing the antibodies, you decrease the immune response. The erythrocytes and the platelets are increased. However, the good effects of glucocorticoids come at a price. Many of the bad effects, if we can call it that, or the side effects of these drugs are actually a result of their function. And we know that their major function is to regulate the metabolism of lipids, proteins, and carbohydrates. Another unwanted effect that we have is a consequence of immune suppression. So this is a bit of a paradox because suppressing the immune system is what we use this drug for. So glucocorticoids promote gluconeogenesis. It wants to make glucose from anything: carbohydrates, muscle tissue, fatty tissue. The rationale is for the body to produce glucose to use as energy in a stressful episode. This results in insulin resistance and even diabetes mellitus in patients that's already insulin resistant. Fat redistribution is in a unique pattern around the abdomen, and you also see extra fat at the back at the upper back, and this is then called a buffalo hump. There is a breakdown of skeletal muscle, resulting in muscle weakness and wasting of the extremities. A dose reduction and strength training may combat weakness and atrophy to some extent. Hypertension. So this is commonly seen and very important, and it's made worse by weight gain, which is also due to these drugs. Bone density decreases, and we see a risk in bone fracture and an increase in osteoporosis. The degree of bone loss is not correlated to the dose taken, so that's quite interesting. Any patient taking prednisolone larger than 5 milligrams daily for 3 months should be considered at risk for osteoporosis. More trabecular bone loss is seen compared to cortical bone loss. This is why you see more spine complications than hip complications. Mood alterations vary vastly, and patients can experience anything from euphoria to psychosis. They complain about insomnia, depression, overall nervousness, and memory loss. Decreased immunity. So here we have our paradox. We use glucocorticoids to have a decreased immune reaction, but this also leaves the patients vulnerable and susceptible to various pathogens. These patients may show symptoms of infection differently because we have now diminished their inflammatory response. Poor wound healing is due to suppressed immune of a suppressed inflammatory cascade, and also a decrease in fibroblast action. We see an increase in gastric acid and pepsin production, especially when given glucocorticoids in combination with non-steroidal anti-inflammatory drugs, or NSAIDs. If a patient is on chronic long-term therapy, then an antacid is beneficial. There is an increased risk for cataracts and glaucoma. So as you can see, the list of effects is very long. But now that we've seen the good and the bad, let's look at how to prescribe these glucocorticoids. Whenever it is possible, topical preparations are preferred over systemic administration. The effects are equal, with the added benefit that the topical drug avoids the systemic circulation and thus avoiding the long list of side effects. Like any medication, it is best used in combination with a clear diagnosis and a good understanding of the disease process. A clear aim of treatment is needed to distinguish between aiming to resolve a lesion or to manage a chronic disease. When prescribing these medications, provide the instructions in detail, write it down for the patients, and monitor the patients to ensure that they use it correctly. You can even recall these patients on day 2 or 3 to ensure that they use it correctly. And also then you can monitor their clinical response and establish and communicate the goal that you want to achieve by prescribing these drugs. In the past, South African dentists have relied on Kenalog in Arabase as a fix-all solution to all the inflammatory conditions of the oral mucosa. This was not the strongest or the most potent glucocorticoid steroid available, and in its absence, we have luckily begun to explore much more favorable formulations, and these we borrow from dermatology, rheumatology, and pulmonology. Obviously, we use them in an off-label form. We can now adjust our treatment strategy by selecting the most appropriate formulation and potency to match the patient's disease experience. Here you can see in dermatology, they use cream, gels, lotions, and ointments. But from these, we usually select the gels and the ointments to use on the oral mucosa. Topical corticoids are grouped according to their relative anti-inflammatory potencies. So here in the table, you can see it's classified from the bottom as very potent, potent, moderately potent, and weak. Contrary to the skin, we do not have the luxury of dry surface areas, which ensures extended contact time between the lesion and the drugs. Instead, we have saliva and the action of oral musculature, and it rapidly displaces the drug from the oral mucosa. Therefore, we often compensate by choosing a more potent drug, increasing the frequency of administration, and even mixing the drug with an adhesive vehicle. And an example of this is Coriga or any denture adhesive. Okay, so if we look here at the pictures, you will see in the first picture on the left-hand side, that's an example of a major aphthous ulcer on the lateral border of the tongue. And in this case, gels and ointments are ideally suitable for solitary lesions, which are accessible for finger applications. Systemic preparations that are available in liquid formulations can be used as a mouth rinse for widely distributed lesions, like you can see in picture B. That is a case of desquamative gingivitis, where you can see it involves a large surface area. So mouth rinses are ideal. A vacuum form can also be used in the same way as we would use bleaching trays to increase the contact time of the drug and the surface area. This leaves the oropharynx fairly inaccessible to either the ointments or the mouth rinse preparations. Here we can use nasal sprays or inhalation preparations, of which 80% is deposited in the oropharynx. as you can see in the lesion in picture C. You can see there's 2 aphthous ulcers in the soft palate, almost in the oropharynx. When we consider systemic administration, tablets and suspensions must be taken in the morning because it has to coincide with your circadian rhythm. This is very important. Tablets do not have the benefit, or do not have a topical benefit, obviously, but oral rinses that we prescribe to swish and swallow benefits from both topical applications to the intraoral lesions, and it adds systemic benefits in more severe and painful cases. High doses of systemic drugs are needed to exceed the therapeutic effect of potent topical agents. A short course of shorter than 7 days do not need tapering when used systemically. The patients are also not required to finish the course. If the glucocorticoids are, if the course is not done and the patient feels better, then they can leave the systemic drug and start using or continue using the topical agent to manage the lesion. Here is a list of systemic drugs available in South Africa, and this is according to the SAMF, the South African Medicine Formulary, with some suspensions available to swish and swallow. As you can see on the left-hand side, Prelone is a very popular drug that we use for this purpose. You can see it's in the intermediate group in the middle of that table. Lesions that fail to respond to topical therapy or lesions that have reached a plateau can be managed through intralesional administration. The aqueous formulation allows for slow release and ensures the drug is released over an extended period of time. The clinical case that you see here is a patient that presented to us in the clinic, and she was diagnosed with systemic lupus erythematosus. As you can see, that lower lip on the top photo was unresponsive to other forms of glucocorticoids, and we used methylprednisolone injection in the lower lip. And at the bottom photo, you can see 3 weeks later, that non-healing ulcer disappeared. She still had some hypopigmentation on the lower lip, but the pain symptoms were gone and subsided. Inhalation preparations is often reserved for respiratory diseases, which includes allergic rhinitis and asthma. But we employ these agents as topical agents. But you must remember that systemic absorption of inhalation preparations is possible. One of the common local complications of topical application of glucocorticoids is the development of candidiasis. This can be in an erythematous or in the pseudomembranous form. And here it mimics the pain experience of an erosive ulcer. And thus, it is mistaken as a treatment failure. It is present in between 25 to 55% of patients using oral and topical corticosteroids. Oral suspensions are worse than the gels due to the larger surface area that they cover. To manage this local complication, a topical antifungal is advised. Nystatin can be used 4 times daily for 14 days, and this is only indicated if the patient experiences symptoms. It's not necessary to give it as a preventative measure. Okay, so glucocorticoids are used to help diagnose and treat adrenal diseases. And then you get a very diverse group of non-adrenal disorders. And this is the setting that we are in. So first of all, glucocorticoids are employed in cancer therapy due to their ability to decrease immune cells. It is also used to prevent organ or graft rejection, and then also in trauma. In both surgical and in accidental cases, their use can be beneficial. Clinicians have the opportunity to preempt inflammation by giving glucocorticoids, and in this way preventing the damage caused by trauma. Glucocorticoids used to be the drug of choice for all types of inflammation. Physical trauma, extreme temperatures, radiation damage. However, due to the side effects and the list being so long, the non-steroidal anti-inflammatory drugs have largely replaced glucocorticoids for this purpose. In the oral medicine milieu, we use glucocorticoids in the management of allergic, dermatologic, and many immune-mediated conditions. So if you look at the table on the right, there are many ways to group these lesions. But for practicality, we will discuss these lesions tonight according to their severity. In potentially life-threatening diseases, treatment has to be tailored to our understanding of how the condition progresses and how the disease responds to therapy. More severe or even life-threatening conditions like pemphigus vulgaris, the case that we have, are managed more aggressively than others. Pemphigus vulgaris, first of all, is considered a rare disease, but it's also a life-threatening autoimmune disease with debilitating consequences. Pemphigus vulgaris can result in multiple chronic mucocutaneous bullae and ulcerations. Patients present with oral manifestation of this disease before skin lesions in 80% of cases. The mainstay of treatment remains systemic corticosteroids. The first aim is to control the disease. So you want the current lesions to heal and you want no new lesions to develop. Systemic corticoids can quickly achieve this, but the many side effects of these drugs necessitate us to use steroid-sparing drugs in the long-term maintenance of these patients. Before the use of glucocorticoids, the death rate of pemphigus vulgaris was between 60 and 90% due to electrolyte imbalance and secondary infections because of the large surface areas involved. Now that we use glucocorticoids, the prognosis of the condition has increased considerably, but now the patients succumb due to the adverse effects of glucocorticoids. In other immune-mediated diseases with better prognosis, topical corticoids can be used as the mainstay of treatment, sometimes supplemented by systemic drugs for faster relief. The application of corticosteroids in these cases should match the complaint and symptom of the patient. Communication between the dentist and the patient is crucial at this stage. The best way to distinguish between these different lesions that often present similarly is to perform a biopsy and send it for histologic assessment. This will empower the dentist, the physician, and the patient to know what to expect from this disease and how to manage it in the future. The case that we see here is mucous membrane pemphigoid, and it represents a group of chronic, blistering, mucocutaneous autoimmune diseases. If only oral lesions are present, sometimes the disease can be controlled by applicating one of the more potent topical corticosteroids several times a day. Once control is achieved, the applications can be discontinued, although the lesions are certain to flare up again. Sometimes alternate day therapy can be used to suppress the outbreak of this disease. In acute flare-ups that we know will occur, a short course of systemic glucocorticoids can be considered. Systemic use is also considered when the eye and other mucous membranes are affected. So the photos that you see on the screen on the left-hand side, it's one of my patients in the clinic. She presented to me last year and she was in severe pain and discomfort. She could not eat. And we managed her with topical glucocorticoids and a short course of systemic glucocorticoids. And then 3 weeks later, on the right-hand side is her follow-up photos. So when I first saw this, I felt that our treatment had failed because you can clearly see the ulcerated mucosa in the lower right-hand side in that photo. But the patient was not complaining. She was in no pain. She could eat. And yeah, from there we managed it with topical corticoid. So this was a lesson for me to learn that you have to listen to the patient's complaint, because even though to me as a clinician, this still looks very painful, the patient had no complaints. Okay, so this is a common benign condition, geographic tongue, and it primarily affects the anterior 2/3 of the dorsal tongue mucosa. They appear as multiple, well-demarcated zones of erythema, with atrophy of the villiform papilla being responsible for the erythema. Generally, no treatment is indicated for patients with geographic tongue. Reassuring the patient that the condition is completely benign is more than enough. And you might tell the patients that spicy food may elicit some tenderness or pain. Topical corticoids can be employed in these cases, or in some cases, where symptomatic relief is needed, or when the patient experiences a burning sensation. Erythema multiforme is a blistering, ulcerative, mucocutaneous condition often associated with herpes simplex, mycoplasma pneumonia infection, and various systemic drugs. Target lesions on the palm of the hands are associated with erythema multiforme. Glucocorticoids are given, systemically a short course, and then a continuous topical agent. You must remember that this glucocorticoids does not cure this disease, and the removal of the causative agent in these cases are crucial. So the patient that we see here, it's also the same lady. She presented to us last year with severe pain. You can see the bloody crust on the lips on the left-hand side on those photos. And you can see the poor oral hygiene as she was suffering to eat or clean her teeth. And you can also see in the far right-hand side, she did not only have target lesions on the palm of her hands, but also on her fingers. So we treated her with glucocorticoids, and then we asked her physician to change her ARV medication, because the history of this patient was that she's been on ARV medications for about 9 years, and 3 months before she presented to us, they changed the regime. And we asked them to change it back, and this is what she looked like 2 months ago. So you can see it's total resolution, and you can see still hyperpigmentation of the lip, but no ulcers being present. So then we have recurrent aphthous stomatitis, and this is one of the most common oral mucosal pathoses that we see. It has a prevalence of up to 66% in the general population. The pathogenesis is unknown, and we suspect that different things causes this in different people. It can also present as part of various other diseases, and these include Behçet syndrome and sarcoidosis, orofacial granulomatosis, and also nutritional deficiencies and malabsorption syndromes also leaves you with these ulcers. We get 3 clinical variations. So first of all, in picture A, you can see the minor form. They are the most common in about 80% of cases. You have fewer recurrences. They are smaller lesions, and they heal quicker. So the ulcer time is of short duration. Then secondly, in picture B, you can see the herpetiform aphthay. And this is a unique pattern affecting about 10% of patients. Then in picture C, you see the major forms. And this is the remaining 10% of patients. So these patients suffer from larger lesions, about 1 to 3 centimeters on average. It recurs more often, and the symptoms is more severe and persistent. It takes very long to heal. It can heal between 2 and 6 weeks. So for these 3 variants, treatment coincides with the severity of the symptoms. Topical agents can be applied to prodromal symptoms as well. Here, a distinction can be made between an ointment for easy-to-reach lesions or a spray or suspension for diffuse or hard-to-reach areas. The outcome in these cases are suspected to be uncomplicated, and you want full resolution of the lesions. Then we have oral Implantology. So this is the most common non-infectious oral mucosal lesion or disease. It is more frequently seen in women, and the typical age of presentation is between 30 and 60 years of age. It can present in various forms, and the areas most affected is the buccal mucosa, the lateral borders of the tongue, and the gingiva. This then represents the reticular form. This is often the asymptomatic form that is picked up on routine dental examination. However, all the other clinical variations with erosions and ulcerations will have some Wickham striae that's visible. So Wickham striae is the raised white lines that is characteristic to this lesion, and it has a lace-like appearance or a spider web appearance. Besides a confirmatory biopsy and yearly monitoring, no active treatment is required. This is a chronic condition, so the underlying disease is constantly present. Topical glucocorticoids are the mainstay of treatment for pain relief, and it's only the most severe cases that you will employ a short course of systemic glucocorticoids. Then lastly, here we have allergic reactions. This can be an acute incident, or it can be in the form of an oral lichenoid reaction. Oral lichenoid reactions are commonly described as self-limiting, but after the agent has been removed. The trigger may be a drug, it may be toothpaste, in some cases it's cinnamon, and other various dental materials, with amalgam being a common culprit that we see, especially there in picture B. You can see the buccal, the large amalgam restoration, and then the lesion on the buccal mucosa that coincides with this restoration. Both in picture A and in picture B, these clinical photos can resemble lichen planus. Unfortunately, it is not always so easy to distinguish these lesions from lichen planus because they can occur months to years after an exposure to a trigger, and it can take months for these lesions to resolve even after the trigger or the causative agent has been removed. That is why a biopsy is important in these cases to determine a diagnosis. The last group that you can see down at the bottom in the red is ulcers non-responsive to glucocorticoids. Chronic ulcerative stomatitis is an example of this. It is an immune-mediated disorder that affects the oral mucosa. This disease is often treated by antimalarial drugs. Patients not responding to glucocorticoid therapy should be referred for specialist evaluation because glucocorticoids are not the answer for everything, unfortunately. So the general prescribing guidelines are indicated in the South African Medicine Formulary. In our scope of practice, we do not prescribe long-term glucocorticoid therapy. However, as dental practitioners, we see these patients in our chairs daily, and we should be aware of what our physician colleagues are evaluating. So first of all, for baseline evaluations, glucocorticoids should also always be prescribed with a good cause. The benefit should always outweigh the risk. Then secondly, the HPA access has to be preserved as far as possible. The bone mineral density needs to be assessed and monitored regularly, even more so in postmenopausal osteoporosis patients. Patients are also often on various supplements to help optimize bone health. An alert bracelet is also helpful to indicate that you are on chronic glucocorticotherapy. So monitoring is very important. The patient should be monitored regularly by a physician when on chronic therapy. The dentist also has a duty when treating patients on long-term glucocorticoid therapy. The medical history has to be updated regularly due to the large list of side effects. You have to check their blood pressure and their glucose levels regularly, and especially before any invasive procedure. You can also assess their general health and their physical health and their psychological well-being. And if you have concerns or if you are uncertain, you can refer them back to their physician. Then lastly, the common denominator, the patient. Communication between the patient, the dentist, and the physician is especially important. A patient already on glucocorticoid therapy, as instructed by his physician, should consult that prescribing physician first before adding an extra script for systemic glucocorticoids, even if it's just a short, non-repeating course. Patients should also play an active role in their treatment because this is sometimes for chronic, lifelong diseases, and they should help design protocols to help manage their disease optimally. So, in conclusion, where is a safe space for us as dental practitioners to practice? So, this is the safe space between selecting an appropriate case, in other words, a mild case that we have discussed. There are others as well, but some of a mild case with a confirmed diagnosis after a biopsy is done. Then we have to choose the correct glucocorticoid. A topical agent is preferred where possible, and then we can use the systemic glucocorticoids when needed. We must also ensure that the patient has good oral hygiene and good communication between the dentist and the patient. Then lastly, you have to stay updated with the current drugs that are available. All our practices have a MIMS in them, or I would also prefer or I suggest having a South African medicine formulary at hand. Use the specialists available to you and utilize learning opportunities like these to assess your knowledge. It's also advisable to contact a colleague or phone a friend if you're unsure, or you're more than welcome to phone us or contact us, send us an email. If you're unsure, we do telephonic consultations, and you are more than welcome to bother us with cases, and and we would gladly assist. So with that, I thank you, Dr. Sudhir and Sada, for having me and creating this platform for us to share our knowledge.
Thank you, Dr. Blignaut, for another enlightening lecture, something that we would definitely be able to apply in our practice. I have a few questions from our delegates. One of the questions are, what effects does glucocorticoids have on the periodontia?
Okay, so in these cases, you have to understand that the glucocorticoids, well, let me say it like this. In these lesions that are so symptomatic, the patients can't clean properly. So even, am I still sharing my screen?
No.
Okay, let me do this. Okay, can you see it now, Nay?
Yes.
Okay, so in a case where you have a very symptomatic lesion, the patients, their plaque control is very poor. So like you can see at the picture there on top. So the glucocorticoids do not have a direct effect on the periodontium, but because it has an anti-inflammatory effects and it suppresses the immune system, it allows this patient to clean better, and that will ultimately help the periodontal health, because we know pathogens and bacterial plaque is a major contributor to periodontal disease.
Thank you. Another question is, what does glucocorticoids bind to? What does glucocorticoids bind to?
Okay, so I suppose what they mean is what do they bind to in the plasma? So glucocorticoids bind to proteins in the plasma, mostly to transporter, but also to albumin, but with a lower affinity. So it binds approximately 90% of glucocorticoids bind in the plasma, and it's only the 10% that's free that allows us to have a biologic effect.
Okay. Another question is, if the ointment is not available, can cream be used topically?
Yes, okay, great. Yes, so I specifically put it like that because we would prefer the ointments or the gels, but the cream can be used. The creams have a keratinolytic factor, which we don't need for the oral mucosa. So that is why the ointment is ideal. But if the ointment is not available, then you can use the cream as well as a second option.
Okay. Another question is, what is the treatment protocol for burning mouth syndrome without an obvious etiology? Okay,
so first of all, I would just say again that glucocorticoids are, should be used very sparingly and should be used with good effect or with a good reason. So with the burning mouth syndrome, I think trying to get to the root of the cause is very important, because there's a large part of burning mouth syndrome that's not physiologically, that's a bit, that can be corrected by adjusting other factors first before jumping to glucocorticoids. So a protocol, I'm not too sure, but I would definitely suggest checking if there's any nutritional deficiencies, maybe checking the general health before only applying glucocorticoids.
We have another question. It's actually about a point of information. I'm not too sure which country this delegate hails from, but we frequently run into a problem in treating oral diseases where the pharmacist refuses to fill the prescription of the patient, stating it is outside the scope of our license practice. Do you have that type of problem in South Africa?
I'm not too sure. When I was in private practice, I didn't employ glucocorticoids. Yeah, I wasn't, in my pre-grad, I wasn't comfortable prescribing glucocorticoids, so I never encountered that problem. And the once or twice that I did encounter, I don't think we have problems. And even now, but in the university setting, we don't have problems, especially with the topical corticoids, we don't.
Yeah, I can second that. And I think in South Africa, it's not really an issue. Another question is, can you please recommend the name of a topical corticosteroid with frequency of application and duration of treatment for major aphthous ulcers?
Okay, so first I want to say that there's a lot of protocols in the literature. So if you're interested, you can go read up on it, because there's a lot of information out there. The one that I use in the clinic, I'm not saying it's the best, but that's what we use and we see good results, is we use a betanoid suspension. So the betanoid, if you now recall the table, it is a potent, it's one of the more potent glucocorticoids. So we use the betanoid suspension, but in a rinse and spit protocol. So you can rinse with it, but you have to spit it out because it is so potent. And then we use it in a combination of 5 milliliters of betanoid suspension and 5 milliliters of water. So yeah, then you increase the volume a little bit. So then they can rinse with that volume for 3 minutes and spit it out. And that they can do for up to 4 times daily. Okay. But it's important to emphasize again that you have to spit it out.
Another question is, have you perhaps considered a herbal alternative such as aloe containing preps for the relief of pain associated with ulcers?
Yes, that's actually a very good question. And last week in the clinic, we had a patient with aphthous ulcers that says she uses aloe vera or aloe products, and she is now growing alvane in her garden, and she says it helps a lot for these ulcers. So definitely, if there's a herbal, non-pharmaceutical option that's legal and healthy and works for you, then for sure, I think that's a very good alternative. I know honey is also one of the patients that suffer from like severe oral mucosal like symptoms. Sometimes rinse with some warm honey, and that also works.
Absolutely, rather interesting question. Is Kenalog in Orobase still available in South Africa?
No, it hasn't been for a while.
Okay, then we have another question is, will extracting teeth in patients with lichen planus cure lichen planus?
No, unfortunately not. So lichen planus is only a mucocutaneous disease. So it's actually, if you classify it, it's actually a dermatological condition, which then spills over into the mouth. And then we have an intraoral situation. So it's definitely not tooth associated. Sometimes if the desquamative gingivitis is very severe, then again, patients struggle to clean, and then they end up with plaque around the teeth, which then makes or aggravates the situation. So that you get a lot. Where if you then remove the teeth, then you don't remove the cause, but the patients don't have the teeth, so the bacteria can't accumulate. So the inflammatory response from the body is a bit less.
We have another question. Are glucocorticoids contraindicated in pregnancy, especially as flaring up can be seen in pregnancy?
Yes, yeah, so that is unfortunate. Glucocorticoids are definitely contraindicated in pregnancy, especially because you now have you're predisposed to possible higher blood pressure, and your glucose, you can be hyperglycemic. So definitely the SAMF also classifies this glucocorticoids as only to use in extreme or life-threatening situations. So definitely trying to avoid that would be better. Not even to mention the effects on the fetus, yeah.
We have another question. Is there a brand of topical cortisone gel?
Let's check. Okay, so let's see. This is now the list as it is in the SAMF. So if we look at the topical, there we have it. A topical gel. So there's a lot of ointments. Betnovate ointment is one that we use a lot, and it's a potent one. And then Dermavate. I think a lot of people are familiar with Dermavate. It is a clobetasol propionate. That is a cream and an ointment. But the gel, I don't think we have it. Some of them do come in gel, but you have to ask your pharmacist.
Thank you. What is your opinion on the use of Medrol Dospac or dexamethasone Dospac in surgical extractions?
I do not have experience with that. But when I hear the word dexamethasone, then I think about it being a long-acting and also a very potent glucocorticoid. So the fact that it does decrease, I just want to go to that slide to indicate the fact that it does, it has anti-inflammatory effects, okay, as you can see there, a very potent anti-inflammatory, but you also want some degree of inflammation for normal healing. So it's a very fine balance between having your anti-inflammatory property and then having proper wound healing.
Another question from Anonymous. There used to be a rule to give the patient their normal GC before dental treatment. If the dose they take is less than 20 milligrams, to double the dose if they use 20 to 40 milligrams to avoid steroid crisis. Is this still so?
I have heard that rule of thumb as well. And I think the best way is to confirm with that patient's physician when you are planning any invasive procedure. But I have heard of it before, that you do increase the dose before a bigger procedure. So definitely, if it's a rule anymore, I'm not too sure, but I think the physician will have a better understanding.
The next two questions deal with ANAG and ANAP. Would you prescribe glucocorticoids for ANAP? And if so, could you give the dosage?
So first of all, you could. Normally, my experience in the clinic is that non-steroidal anti-inflammatory drugs work quite well in combination with chlorhexidine. That is a good combination to treat, especially if it's NUG. So in other words, it's necrotizing ulcerative gingivitis. So then by definition, there's no periodontal involvement. So here I would say, I think non-steroidal anti-inflammatory drugs and chlorhexidine would be enough. If not, and you feel that it's very severe, then I would definitely use a topical agent. You can use Prelone, which is a prednisone systemic oral suspension that you can use. The Prelone it works quite well, and it's not as potent as the petinoid. But I think you should be able to get away without steroids in ANAG situations.
And in the same instance, regarding NUG and NAP, does one still take biopsies, excisional biopsies, enough in establishing the treatment regimen?
For NUG, we normally do not take biopsies. So what you would do is you would treat the pain and the inflammation with your non-steroidal anti-inflammatory drugs and your chlorhexidine. And you can also use chlorhexidine gel for a longer application time. And then you would get that patient back 3 to 4 days later, and you would clean the area, because here it's not an immune-mediated reaction, it's due to the pathogens. So then as soon as you clean it out, the plaque, the calculus, then most likely the condition will clear up without you having to do a biopsy.
And I believe this is our last question for tonight. Please name a few contraindications of corticosteroids.
Okay, perfect. So you have some, let's say a patient is hypertensive or is already a diabetic, then that would caution you to use extra glucocorticoids, right? But in cases of an absolute contraindication, I think severe infections is right on top of the list, and then also pregnancy. So severe infections would possibly in our setting maybe include osteomyelitis or even a TB infection. For those, you would caution on using glucocorticoids.
Super. There doesn't appear to be any more further questions. Right. thank you so much, Dr. Blignaut, for an enlightening evening, bringing us back to oral medicine, giving us a bit more bullets in our armory to attend to those unique cases that we get in everyday practice. I must thank you once again for availing yourselves tonight.
Yes, and thank you, and thanks to Sarah for this platform. I think it's a very good initiative and a very informative
And
previous webinars.
Just before I conclude, I think we have one more question.
Okay.
Is the use of betnovate ointment for major after ulcers an overkill?
No, it's not an overkill if the symptoms and the pain is severe. So if the patient complains about, if it's very painful and symptomatic, they can't eat, they can't function, then to use betnovate, you can use it. And as soon as the symptoms disappear or the patient can manage the lesions with non-steroidal anti-inflammatory drugs or other pain medication, then you can leave the betnovate. So it's only for the flare-ups that you would employ that drug.
Super. Once again, Doc, I must say thank you. And it's also an inspiration to find a fellow young dentist in the position that you're currently holding. I'm sure that's a platform for many other younger practitioners to follow through. And once again, I must thank our delegates for availing themselves tonight. Without you guys, there won't be that ecstatic environment that we have in our webinars. And also the guys behind the scenes, Marlies and the other guys from head office, Noma, for their efforts in ensuring that our webinars go ever so smoothly. So I must thank you guys as well. And thank you so much, Doctor, for another enlightening webinar tonight. And with that to say, I would say thank you all for attending and have a good night.
Thank you very much.